Next is the high risk surgical patient. What comorbidities would you expect a high risk surgical patient undergoing a major complex procedure to have? So again, a very common question, but we never answered with exam perspective. So it's common sense. If someone has a high BMI, someone has coronary artery disease, heart failure, COPD, diabetic, hypertension, stroke, peripheral vascular disease, smoker, these all make the patient a high risk. And how do you optimize such patient prior to surgery? So there is a system to assess the patient before surgery called pre-assessment, and they check the patient all medical conditions, their medicine, their functional capacity of assessment, and if they found anything regarding cardiovascular system, they refer to cardiologist. Any respiratory system, refer to the respiratory physicians, and then so that we can accurately calculate the risks, benefits of the procedure intervention to tell to the patient. How do you assess a functional capacity? So again, a very subjective and very vague, very wide, broad term. So again, physical activities you can check by WHO scoring system by 0, 1, 2, 3, 4. 0 means patient is fit and well to sternus exercise. 1 means patient has a limited sternal exercise activity. WHO's performance status. 2 means 50% they are out of the bed and they do all their basic needs of the life. And 3 means they are bound 50% of the time, they are bound in the bed. And then is anesthetist generally asks, can you walk 2 flights of stairs without getting any symptoms? So they are actually checking the metabolic equivalent. So if someone can easily walk 2 flights of stairs without getting symptoms, it's mean they are fit for general anesthesia and they will have a good outcome. And then the objective test is cardiopulmonary exercise testing, in which we use the VO2 max and anaerobic threshold. 80, we call it 80. So, and then we exercise ECG testing, and then stress pharmacological stress testing using the perfused heart scan, and then the butamine stress echocardiography. What risk factors produce this patient to acute kidney injury? Again, a very broad, common questions we never answer in our exam perspective. So acute kidney injury means any patient who is old age, who have a chronic kidney disease, CKD, and diabetic, ischemic heart disease. If someone has perioperative dehydration or they are on nephrotoxic drugs, remember the 4 group of drugs: ACE inhibitors, angiotensin receptor blockers, aminoglycosides, and diuretics. And contrast load, especially all the radiology CTs with contrast. So what measures can you take to prevent the AKI? So perioperative good hydration, as the less pre-op starvation time, cardiac output, good cardiac output during the operation by intraoperative fluid, pre-procedure fluid administration, good urine output, replace blood loss promptly and monitored by near patient testing, and avoid perioperative hypertension, and avoid the nephrotoxic drugs, especially the NSAIDs, minimize contrast load. And if someone has a recently contrast, you can wait, there should be a gap so that kidneys can recover. Good glycemic control using sliding scale regime, and embolization of the erythematous plaque into the renal arteries. Obstruction of the renal arteries by stent may occur as a part of the surgical procedure. Thank you.